Hi, I'm Connie McNeil. I'm a registered nurse and I've worked at a systemic sclerosis clinic now for 5 years. I'm going to talk to you about wound care on our scleroderma patients. So many of our patients get many digital ulcers or other kind of cuts or injuries that have difficulty healing on their hands due to Raynaud's. So I just have some basic information on wound care at home and then how we advance that if we need to. Most wounds heal best in a moist, warm environment. So the best thing to do with a digital ulcer on a scleroderma patient is to apply a bacitracin and a Band-Aid daily. That keeps your wound moist and it keeps it warm, and it'll heal much quicker than if you leave it open to air and not treat it with anything. I usually suggest 2 weeks of treatment with a daily Band-Aid and bacitracin change. And then after 2 weeks, I want them to send a picture or photo through their electronic record or through my email. And then I will triage it to see if it needs more advanced wound care at that time. Once I've determined that if it has signs and symptoms of infection or it just isn't healing from the state it's in after giving it 2 weeks at home, then we will send them to a wound care clinic that has hyperbarics and other advanced treatments. If it appears infected, such as has redness, swelling, tenderness, or has started draining a purulent drainage, then we would send them to infectious disease as well. I've had the opportunity to work with different clinical trials with digital ulcers and other skin ulcers on scleroderma patients, and we've seen great success with different modalities of treatment. One is amniotic membrane, and so if you have an opportunity to be part of a clinical trial for wound care, I would encourage you to do that. Thank you for your time, and I wish you all well.
Hi, I am Rachel Lando. I am the support group leader for the Salt Lake City Greater Support Group for Scleroderma. I'm also the founder of a program known as Patient Care that brings movement to those living with an autoimmune disease. So, my experience with wound care. Let's talk about the good, the bad, and the ugly. So, for wound care, digital ulcers tend to be a very common symptom of living with scleroderma. It's one of the ailments that's very difficult to treat because we use our hands often, and yet we don't receive a lot of blood flow to the hands. And so these things can digital ulcers can rapidly deteriorate and rapidly become infected, which means that they deserve 100% of our attention. It's actually pretty hard not to give them attention because they are so darn painful. That's the truth. But anyhow, so digital ulcers, in my case, tended to appear on the middle knuckle. For many people, they appear on the tips of the fingers. And we need to monitor them for a couple things. One is redness. The other is increase in pain, spreading of redness. Sometimes they can also appear a little white. If any of these things happen, it is very important to speak to a wound care professional or just seek counsel from another doctor. They're very difficult to treat, in fact. In terms of, so that's kind of the good, I guess, that they are treatable. In terms of the bad, you're going to find a lot of solutions online that may or may not work. The most effective treatments tend to be the ones recommended by your doctors, including antibiotics. Sometimes they may be oral, sometimes they may be topical, as well as proper dressings. And this is where, and this can be ugly, the dressings can be ugly. This is where patient education is so important. You need to learn from a professional how to properly dress, manage, and clean these wounds. This can be challenging, especially if you live with hand deformity from sclerodactyly. But your provider should teach you how to first clean the wound, then how to apply whatever topical treatment that you've been given, how to cover the wound in a way that's comfortable and safe and clean, as well as how to tape it up. Now, in addition to cleaning and managing daily wound care, there are a couple other options that I have personally been through, personally undergone. That includes hyperbaric wound care. This sort of treatment can speed up the process of healing for the wounds by targeting the tissues. My absolute favorite solution has been in a clinical trial with amniotic tissue, in which they overlaid amnion over the wound. That yielded the absolute best results. You're gonna hear, you may come across different wives' tales, different ways to treat them. And I would say some may work, but I would still caution you from trying those without first consulting your doctor. I have had mixed experiences not listening to my doctor, and I do not want that to happen to anyone else.
Hello, I'm Kurt Bernhisel. I'm the medical director here at the Research Park, University of Utah Research Park Hyperbarics and Wound Care Center. I am a professor of surgery in the Division of Emergency Medicine and have been doing wound care for about 10 years. I've been the medical director here for the past 3 or 4 years. So today we're going to be talking about some scleroderma, how we take care of that here in the wound care clinic. And we'll also talk just about some general things that we do in a wound care center. So maybe we'll start about some of the general things that we do in wound care. Wound care is kind of a multidiscipline type of clinic that we take care of a whole variety of different types of wounds. Almost all chronic wounds, non-healing wounds, problematic wounds. The big ones that we see are diabetic wounds, venous wounds, post-surgical wounds, all wounds that have had trouble. Wound healing occurs kind of in 3 different phases. There's kind of an inflammatory phase, a proliferation phase, and then a remodeling or final repair phase. And most of these chronic wounds get stuck in the inflammatory phase. So we try to do different treatments to get them out of the inflammatory phase onto regular healing. One of the things we really worry about is wound infections, and we're going to get to scleroderma here in a second. But wound infections are always a problem. We have a lot of colonized wounds, and then there's a concept that they can either be colonized, critically colonized, or infected. And so many of these wounds, we do wound cultures, try to get deep wound cultures to determine if there's really that as a problem, one of the big common causes of wounds getting stuck in the inflammatory phase. So we also want to talk about the type of dressings that we use. And there are numerous types of dressings that you can use. We like different types of healing salves. We talked a little bit about using some Metahoney. Metahoney is one type of dressing. Interestingly, it comes from a specified bee in New Zealand that has increased levels of growth hormone and hormones and different factors that can help with infection, help with inflammation, and cause healing, help healing. Specifically, should we talk a little bit about scleroderma?
Sure.
Okay, so Tracy Frech has been nice enough to send us a number of patients. We've had several others come in with upper extremity chronic wounds from their scleroderma. As we know with scleroderma, it's a problem with dysregulation of collagen, and we get thickened fingers and wounds. We get chronic wounds that occur, and on these wounds, they tend to be can be very debilitating wounds. And one of the types of salves that we use here in the clinic are calcium channel blocker medications. We use some nifedipine, fenofibrate, which is I don't know if it's something that you can get in a commercial preparation. We actually have it compounded and at some of our different pharmacies, and we apply that fairly liberally to wounds. It seems to help by kind of a collagen regulatory factor. It allows the wound to begin healing by allowing the collagen to not form so readily. It allows the tissues to form angiogenesis, and we get new wound tissues from that. And it's something that some patients can only tolerate by using the salves. It's not something that we only give orally. I mean, there's the different calcium channel blockers that are prescribed, but it seems to work very well on tissues that you don't have quite as many side effects. Have you had any experience with?
I have. I've used the knife-fed compound, and it did heal the wound more quickly. However, to be perfectly honest, I didn't see a major difference in terms of the duration of healing between the knife-fed compound and Metahoney.
Oh, really?
Yeah, I didn't find them to be terribly different. If we were to use both, if we wanted to overlay the knife-fed with Metahoney, would they work in conjunction with one another?
They could. You know, Metahoney has a lot of different properties, but one of them is not the increased blood flow that we get with the nifedipine compound. As we know, with scleroderma, it can cause vasospasm and decreased blood flow. So the nifedipine tends to also improve that blood flow. So we think that using one or both would be much better than just using the Metahoney alone.
Yeah, and I combine the Metahoney with mobilization techniques to try to improve blood perfusion.
Blood perfusion,
so
yes.
I've seen that happen.
Yeah, and I know a couple of our patients that we've seen have been getting physical therapy, and I don't know if that's something that has been tried routinely, but trying to keep our contractures from developing and improving the mobility of the fingers can be very valuable as well. One thing that we would love to be able to do on our patients but can't get insurance approval is often the hyperbarics. Hyperbarics is something I think if we had a little more research and insurance approval could be of benefit. One of the big properties of hyperbarics is that oxygen stimulates angiogenesis, and as we know, that would be very beneficial for our scleroderma patients, but we don't have a body of research that allows us to get most of these people approved. There are certain insurances that will cover it, but the vast majority will not. But hyperbarics would be potentially a very big game changer if we had the research to prove, to try to get our insurance companies to allow us to use hyperbarics.
I actually did do 3 months of hyperbarics here. Hyperbaric medicine. Yes, I did.
You did?
Dr. Dijon, yeah.
Did you have underlying osteomyelitis?
I did.
See, that's the key. So most of our patients that are scleroderma patients get bone absorptions, acrolysis, but most of them do not get osteomyelitis, the deep bone infection. If they do, then it is an indication. It's almost like the cow is out of the barn by then. But if you can get that approval by having osteomyelitis, which is kind of a drastic means of getting insurance, but if we could get it before they developed osteomyelitis, that would be more beneficial.
I hear you basically saying patients don't intentionally get osteomyelitis.
That is exactly. You do not want osteomyelitis.
The hyperbaric did also help. I had ulcers all over the rest of my body at the time, and they did help permanently heal the ulcers.
We know it's very beneficial. Anecdotally, we can say, hey, this is beneficial, but it's getting your insurance to pay for it that often is the rate limiting step and can be very difficult. let's talk just a little bit about infections. We kind of briefly talked about that. But wound infections are one of the big problems that are unrecognized by many clinicians. So if you're dealing with patients with chronic non-healing wounds, most clinicians know if it's red and hot and draining and there's pus, it's infected. But the problem is so many wounds, and research show that it may be 30–40% of wounds, have none of those things. They just stop healing. They stop in this inflammatory phase of wound healing. And so those are the ones that we often culture. And if that turns out to be negative, if it's positive, it's pretty easy. We treat it. It's usually a broad spectrum antibiotic. Most of these are staphs and strafs. A few of them are gram negatives, but that's easy. But when it's negative and they're still stuck in that phase, and if you have a clinical suspicion there might be a subclinical infection, we still treat these patients. It's just like there's not going to be too much downside, other than maybe allergic reactions or problems, but we tend to overtreat some of these wounds if they're in that inflammatory phase and not improving. Did they treat you with antibiotics?
They did. So are you saying that you treat all patients even with antibiotics, even if
not all of them? It's the ones that we do our conventional dressings, we do our routine things. Sometimes we can get them approved for skin substitutes. We have all these different things, but if it's still not getting improved, that's when we say, hey, let's just try to culture them. If that's negative, they're still stuck, we'll put them on a trial of antibiotics. And many of them, that all of a sudden they turn the corner and things start getting better. But we don't treat all of them. No, that's a little too far to go. Yeah.
Good. And then do you ever treat them with just, would you treat some non-healing wounds with just the nifedipine compound too?
Well, many of the wounds that are, from Scleroderma, that tends to be our go-to salve. We've had quite a bit of success with it. Again, it's because we think it improves blood flow, we think it helps. And so if we're not getting an improvement there, if it tends to have, and we haven't really talked about it, but if a wound has a lot of slough, I don't know what your wounds were like, but slough is kind of a yellow, dry drainage type of material. It's a biofilm that a lot of people know things about. But if we can't get that slough off, then the Metahoney, and one of its other properties, is a little bit of enzymatic debridement. And so that can soften the wound and allow healing to occur from the Metahoney as well. And you say that with yours, you had both Metahoney and the nifedipine, and you thought the Metahoney was better?
Yes, I lived with chronic ulcers for like many years. Only now has it really resolved. And I found the same effects from the Metahoney, which also I think have a natural antibiotic in them. Is that correct?
Well, the Metahoney does not have a true antibiotic in it. It has some anti-infectious properties, seems to help. We also use other things. Silver is one of the big products that sounds like witchcraft, but silver really does work. And with a number of antibiotics causing side effects and bacteria developing resistance to antibiotics, silver has had a huge resurgence. And many of our patients here in the wound care center we use with silver. Did you have any bandages with silver? Or?
I did. I used bandages with Silvadene. Is that what it's called?
Silvadene is like the burn unit. That's like they buy it in gallons. But we have some other ointments and salves and dressings and bandages with silver in them. They're not quite as strong as the Silvadene, but usually you don't need that much unless they've got extensive wounds like you would in a bad burn.
So are you talking about now like the Mepilex bandages with the silver?
Yeah, there's Mepilex, there's all kinds of other ones. We use some collagen products that contain silver as well. Prisma is a trade name product that we use a lot that has silver in it. And there's a number of other dressings and bandages with silver that does confer some antimicrobial activity and benefit for dressings and bandages.
So no infections and no werewolves.
Yes. Very good.
So when you were talking about slough earlier, is that the breakdown of the extracellular matrix, or what?
It is. It's kind of a waste product. It's an exudate, almost a dry exudate that sticks on the wound, and it's a form of biofilm. And biofilm is a matrix between bacteria, fibrin, and collagen. And what it basically does is cement the wound bed so the wound bed can't breathe and begin to heal. And so we use a number of products to try to break down that slough, and we don't do this with scleroderma a lot, but a lot of our wounds we take scalpel, sharp debridement to try to get that slough off there. Scleroderma and most vasculitises, we do that very cautiously. We might try to, if there's a hard nodule or something that we can, and there's a scab, a fibrin scab or something that we can get off to help that wound breathe and heal, we'll do that. But we don't do the radical sharp debridements that we do on many other types of non-vasculitic chronic wounds.
And that's to avoid damaging the blood vessels.
Yes, yeah. With vasculitis, we almost don't do it. Only a few of us will feel comfortable enough to try to get a little off without damaging the matrix of the wound bed itself.
Is the protocol still in Europe to debride, though?
It's controversial, you know. Vasculitis and debridement, sharp debridement is probably, according to people I've talked to and read and other wound care people, we're very cautious about that. You can use other things like wound vacs or mist sprays and ultrasonic things that are less damaging to the tissues underneath, and that might be better. But some places in Europe, maybe for example, a lot of places, they probably don't have that technology in some places, and they say, well, let's just do sharp debridement, or we're not going to do any debridement at all. But most of the rest of us try to be cautious and don't do a lot of sharp debridement in vasculitis, i.e. scleroderma.
With the hyperbaric treatments, how long generally is a session?
Okay, yeah, let's talk about hyperbarics a little bit. Hyperbarics, as most people know, started out as a diving injury treatment, okay? And now we have a lot of research. We have numerous hyperbaric centers all across the country and in Europe and other countries. And so when you get an approval to do some hyperbarics, it's a minimum of 20 treatments. We can't get enough healing short of that. And so a hyperbaric treatment generally lasts 90 to 120 minutes, so an hour and a half to 2 hours. And we take people down to generally 2.5 atmospheres of pressure. So it's like taking somebody, 30 to 66 feet below the sea level. And as most people understand, with oxygen treatment, if you put somebody on nasal cannula, you can increase their oxygen percentage on their hemoglobin from maybe 95 to 100%. And the more you give them, you can't get them any higher. But if you put that oxygen under pressure, and that's what we do in a hyperbaric chamber, we force that oxygen into the plasma, and we can increase the amount of oxygen that we deliver to tissues, 10-fold, 20-fold by getting that oxygen in the plasma, and then it offloads when it gets to the tissues. And so that is a signal for the body. They have all this oxygen, and the signal to the body is, wow, things are growing. We've got this garden. We need to give all this nutrient, and they begin to form new vessels. And that's the whole process of angiogenesis that can improve a wound by creating new tissues and new vasculature to that, and it's actually the body's way of healing itself.
Does this have anything to do with anything spatially? Like, I'm thinking about when you go underneath, the compression of the body changes. Does the compression of the body change at all?
Yeah, well, you're getting this pressure, and you can get, and we teach people how to equalize their sinuses, equalize their ears. It does have some rare complications. You can pop a lung. You can have some serious problems. So when we teach a patient how to equalize, it's like learning how to scuba dive. They have to learn how to gradually pressurize their sinus cavities in their inner ear so they don't get an acute squeeze, an acute pain, or a ruptured eardrum from it. Yes.
I did 3 months of this. I am sitting here today and telling you everything went just fine.
Oh, good.
So I just want to reassure any patients watching this.
It's a rare occurrence. We do, have to probably about 5 to 10% of the time put do a earpieces, tympanogram, what's it called? Tympanocentesis. We have to put ear tubes like kids get for ear infection. We have to do ear tubes in about 5 to 10% of our patients because they can never learn how to completely pressurize their inner ear.
Can that affect their balance after they come out?
It could if you were to rupture, and unfortunately, I've probably seen in my 10 years about 4 or 5 people rupture an eardrum. They usually don't have anything other than some acute sharp pain, and then when you look in the ear, you see some blood on the eardrum. But if you don't learn how to do it, that is a potential complication. Yes.
One more question, which is, when should patients contact you? At what, a lot of times people living with scleroderma are really accustomed to living with pain.
Mm-hmm.
And so how would you describe which pain level that people should come to you for wound care?
Well, we think that almost anybody that has a chronic non-healing wound should at some point see a wound care specialist, and there are multiple of those. Now, a number of your specialist rheumatologists, internists, can take care of some of the basic wounds. But if the wound is not healing, if it's getting worse, if you're worried it's getting infected, and the patient is having more and more pain, I think it's at least worth a consultation by a wound care specialist, and potentially they're going to be able to prescribe either different treatments, different bandages and dressings like we've previously talked about, maybe try some of the calcium channel blockers either orally or the creams, the medicated honey, things that we deal with on a daily basis that most of the specialists and primary care people that are dealing with scleroderma patients are not doing or are comfortable with dealing with. So that would be the time to actually get in for a wound care consultation.
And then will you instruct patients on how, on their own home program, how to manage everything?
We do. And some of our patients, we have to get home health involved as well. And that's a great thing, so that some of the patients that don't have the mobility to get into clinic easily, we call and talk to their home health nurses and prescribe the same sorts of salves and dressings and bandages so that home health can deliver those and apply those as necessary.
Interesting. Thank you.
You bet.
Yeah.
My name is Tracy Frech. I'm a rheumatologist, and I just wanted to speak a little bit to your rheumatologist's role in wound care. So your rheumatologist definitely cares about your wounds, wants to hear about your wounds, and wants to take good care of them. And hopefully with this video, you can see it's really a multidisciplinary effect. First, we have our nurse educate our patients. And I think that's really the most important thing, is prevention. And so as we've really talked about, Raynaud's is really the etiology of a digital ulcer. So making sure that your Raynaud's is well controlled is a really critical part of managing a wound, both before it happens and during treatment and after. And so please do talk to your rheumatologist about which vasodilators you can be on. And again, if there's any additional products, whether they be in clinical trials or topical options that can help heal that wound. I also think it's really important, communication and having your patient have the ability to upload images and get information to you promptly is critical. So a wound untreated can go bad really fast. Rachel, maybe speak a little to how fast, a wound that just caused you a little bit of pain ended up infected.
Sometimes it can take as little as 3 days for a wound to open and then suddenly become completely encircled with red inflamed tissue. And that can quickly lead to an infection, which can become a chronic infection lasting years. It is so important to keep your hands covered. It is so important to communicate your symptoms and be educated on the level of pain that is inappropriate, that signals distress of the tissues.
And that's such a good point, because there's something called critical digital ischemia, where the finger doesn't get any blood flow. And so a very, very painful finger, even if you don't see an ulcer yet, is something your doctor wants to know about. That treatment involves imaging as well as really a robust vasodilator treatment. And with imaging, I think that's one of the frustrations I imagine as a patient. You call in, you upload your image, and you're sent to go get an image. And this can either be an X-ray or an MRI. but that's really a valuable or helpful tool to say, is there infection in the bone, or is this on the surface? And so I always say, when you're in that much pain and someone makes you get another study, I'm sure that's very frustrating, but the importance of getting that early imaging so that your treatment plan can get into place. Another thing I'll talk about, maybe more people on our team. So we oftentimes will have infectious disease doctors involved. The reason for that, particularly when lots of antibiotics are used, you can get resistant organisms. And so we want to be smart, not just empirically treat with antibiotics chronically. So maybe 1 round of antibiotics or 2 rounds, but once it's not healing, that wound culture and talking to the infectious disease doctors, sometimes we'll recommend bone biopsy and some other things to really ensure we're treating the right organism. Maybe speak a little bit to your bone infection and kind of yeah, I know.
So I had a case of MRSA about, it was 8 years ago now, but it progressed really rapidly into osteomyelitis, even though I was already seeking treatment for it. I noticed that the pain was really intense, and there were other systemic symptoms as well, pain throughout the body, indicating that there was an infection, an irregularity somewhere. I ended up being hospitalized for this. It ended up needing 3 months of hyperbaric treatments as a result, and frankly it almost resulted in amputation as well. It is so important to go in and get the cultures. MRSA especially, it can progress so rapidly, and so necrosis can happen so fast, the effect of it. So
No, and I think that's a really important point, is you know your body best. I always tell patients this. So if you know something's not right, make sure you're asking your doctor. You never feel like you're pestering someone. Advocate for yourself, which I think is a really important message for all patients.
Yes.
Is if you're in pain and this is not healing, you really do need more advanced imaging, cultures, and a wound care professional. So I just wanted to take a time to thank Rachel for joining me, who has been a blessing in my life and many others as our support group leader, and taking time out of her busy day to make sure that we communicate to patients the importance of taking care of wounds. So with that, I'll thank Rachel. I'll thank Connie, who is a nurse that has done wonderful wound care for our clinic for many years here, and Dr. Bernhisel, who was kind enough to kind of take us around what a wound care offers. We'll show you some pictures of salves and hyperbarics here. And again, thank you for your attention.
thank you, Tracy. Dr. Frech, you are such a beloved rheumatologist for the entire Scleroderma community, and I hope you know that, and I hope everyone watching this video just takes your wisdom and applies it to their patients.
Thank you.